Hi, Melissa Godwin, my colleague and friend from University of North Carolina School of Social Work, and that's the umbrella, and more specifically, Behavioral Health Springboard, where we both work, but in our own little ways and separate lives to some degree. Welcome. Thank you for joining me and the Substance Abuse Policy course. Thanks again, Melissa, for joining. And I wonder if you could just introduce yourself.
Sounds good. Thank you so much, Mike, for having me. I appreciate it. So I am with the School of Social Work and the Behavioral Health Springboard, and my position is completely on a contract with the State Division of Mental Health, Developmental Disabilities, and Substance Abuse Services. And so part of my position for the division is to be the coordinator for something called a Work First Child Protective Services Substance Use Initiative. And so that's one piece of my work. And then the other piece of my work, and my dogs are getting rowdy now.
You warned us. Yeah, that's right.
I did.
It's all good by us.
Okay.
So,
okay.
Yeah.
I'll try not to be distracted by them. So that is one piece of the work. And then the other big piece of my work is doing women's gender responsive substance use disorder services technical assistance. And both of these roles or hats, if you will, are statewide. And so I work across the state. I work with both state level Department of Social Services or the Division of Social Services and the Division of Public Health. And I work with county health departments, county social services, as well as local management entities, managed care organizations, and then providers of services themselves, doing a lot of training and technical assistance. And then I also, with the state, do some policy work related to both of those buckets of things that I work on.
Sounds like you can not only work on the macro level of the policy, but then still macro level, but leaning toward the application side when you go in with consultation with providers.
Yep.
And Melissa, I'm guessing as you're working on state and county, more local guidelines and protocols and policies, you're always having to do that in the shadows or the intersection of federal regulations.
So yes, all of the things that I work on are ultimately dictated or guided first by federal policy, and then the state has to follow to the letter of federal policy and or law, or they have leeway. And so one of the areas that I work in terms of women's treatment specifically is guided by a federal block grant, the Substance Abuse Prevention and Treatment Block Grant that comes to the states from the feds. And there is a part of that block grant for all states that is called a set aside. It's the women referred to as the women set aside. So 5% of the block grant that goes to all states is set aside for women's treatment specifically. And then within that, there are requirements for states. So it's that if the state is accepting this block grant money, then you have to use 5% of it on women's specific treatment. And then there are really specific guidelines for what that means and looks like. We are very fortunate in North Carolina that we have had advocacy for going on 30 years within the state at the division, DMH, DD, SAS level, to expand that. And so in North Carolina, we actually spend more than 5%, 5% of that block grant on women's treatment services. And so that has meant that over time, we've really been able to invest in something called the Perinatal, Maternal, and CASA Works for Families residential substance use services. And so we have a network across the state of both outpatient, but significantly residential treatment services for pregnant and parenting women. And to go back to the federal set aside, the reason that happened the way that it did, the reason the feds required that is because historically, women weren't being served. Women were treated sort of just like men, And those services and the more traditional approaches to treatment weren't working for women. And so they would either not engage at all, or they would leave treatment prematurely. And so there was a recognition that women's treatment needed to look different and be different. Some of that has to do with the significant levels of trauma that may be interpersonal trauma and relationship related. And then there was also the aspect of parenting. And so women often had to choose between being a parent or getting well and into recovery. And so women's services acknowledge their central role for many women, certainly not all women, but for many women as parents. And so in our residential programs, they come in with their children. And so they're not asked to figure it out and somehow magically find, a safe caretaker for the child while they go, get well and get treatment. And the same is true for pregnancy. And so still, there are a lot of programs across the country that will not accept pregnant women into their treatment programs. And it's, I think, has to do with almost a lot of different things, including additional stigma. And not being equipped, and fear of liability, sort of an increased fear of liability about if something goes wrong with the pregnancy, or something, happens for her in terms of if she returns to use or relapses and she's pregnant, is somehow the program implicated? And so ultimately what that means is, in the programs that don't accept women are out of luck. And so again, that's why there was this federal, and still is this federal requirement, that there has to be money that is set aside specifically to address those issues. Because of course it's even more imperative, I don't know if more imperative is right, there are 2 or more lives in the balance when she is pregnant, and looking for treatment and help to get into recovery.
Yeah, I can see that stigma causing barriers, at least in 2 categories. One, the one you mentioned, is just less services being available. And I can only assume that conventional historic treatment was developed primarily by males and for males, and to think that that would shift, and I would probably say also predominantly early on white males. So to think that that design would work for populations across the spectrum, of course, it's not going to happen. The other stigma side of that is people won't seek treatment. So you have people not offering treatment, but you also have people, because of the stigma, particularly around parents, particularly moms, I think more than fathers, the stigma around that, they're not seeking treatment in the first place.
Yeah, and it's an interesting phenomena that for, the stigma that is around substance use disorders, and the internal shame that people feel around it that can get in the way of asking for help, is in terms of culturally and in our society, is like tripled or quadruple when a woman is pregnant. In my observation, in working for over 20 years around this issue, there is this almost expectation that women magically become, or should magically become, well, and sort of throw all of their pre-existing life experiences and struggles and health struggles aside for the sake of the pregnancy, as if they could choose that, which they would actually if they could. And so when they're not able to, there is this just significant shaming and stigma that happens. And so when they ask for help at hospital emergency rooms, from child welfare sometimes, from lots of different places, from their OBGYNs, they can be just the attitude that they get is pretty profound. And so actually a lot of what I do is working with those, what I just mentioned, so healthcare providers, child welfare, sometimes probation officers, different professionals that interact with women of childbearing age who may be pregnant, to help them understand that this is actually this really crucial time where she is uniquely motivated when she is pregnant, we have found, to enter treatment. And so to be as non-judgmental as possible, to lend that hand of hope, to let her know there actually is treatment available in North Carolina, is really, really crucial and important. And it's just an ongoing work to help people understand that, to open the door and extend a hand rather than to shut the door on her, because that does not help anyone. And we want her to have a healthy pregnancy and a healthy pregnancy outcome. And the sooner she gets into treatment, the more likely that is. And we want her to have a healthy and positive parenting experience. And so that's one of the things I try to help people understand is we all have the same goals in terms of her being able to keep that child as long as, and she's more likely if she's in treatment and in recovery to work on parenting skills. And that's actually one of the aspects of gender responsive treatment for women who are pregnant and parenting, is that all our residential treatment programs, there is a parenting component. And so they are working on that very specifically. And there's a lot of reunification that happens. Women that go into residential treatment may go in pregnant or may go in with a little one, but they don't have custody of maybe some other children, but child welfare is able to work on reunification when they're in this structured setting where they've got a lot of support and they're very specifically working on parenting and their recovery. So
they can be working much more systemically.
Yes.
Now, in some ways, I think of how we interface day to day with our clients as those soft skills, as some about what you were speaking. I wonder about a hard policy that also creates a barrier. And what I'm thinking about is a duty to report if a woman comes in and she's addicted to opioids. What are the policies nationwide or in North Carolina, and or how have they shifted? And you've been involved in some of that work.
So currently in North Carolina, the child welfare law and policy is that there is not the child abuse laws in North Carolina do not extend to pregnancy. And so that is significant in that that means that she can access help during pregnancy without risking getting involved with child welfare during pregnancy. And, it's a fine line, and I recognize that. I think we just know that, so that is true in North Carolina and other states where they have made substance use during pregnancy illegal and something that is reportable. What happens is women go underground. Pregnant women go underground with their use. They don't go to prenatal care and they don't seek treatment. And so that is not contributing to the outcomes that we want. And so there is just consistent advocacy in terms of what the evidence shows, what history has shown in terms of the goal of better birth outcomes, better parenting outcomes, mom in treatment and recovery, is for that not to be the case. And so that's something that comes up periodically before our state legislature. I think it can be counterintuitive, and there are a lot of things around pregnancy and substance use that can be on the face of it counterintuitive. There is a well-intentioned belief that if we just focus on the baby and the baby in utero, and that, and this belief that she's harming this child if she's using during pregnancy, and if we threaten her or punish her or jail her, that is going to lead to a better outcome. But again, if we go back to research and evidence, for example, when you look at birth outcomes where women have been incarcerated, and there are women that are incarcerated in some states for substance use during pregnancy, the birth outcomes are not good. It's a stressful environment in jail. She's not getting great prenatal care or nutrition, or all of the things you would want for a good birth outcome. And so jail isn't the answer. And it can be short-term, feel like there's an action being taken. to help that baby, but actually, it doesn't get her into treatment. It doesn't help long-term outcomes, and it doesn't help the short-term birth outcome, which is significant in terms of the impact at long-term for that child.
It's not helpful to take the person off the street and incarcerate him and hope for a better birth outcome. How about as a deterrence? We are going to make this illegal with the threat of imprisonment, so you don't do drugs while you're pregnant.
Well, I think that we know that drugs are illegal, right? I mean, this is something I've worked with, young people around in my past, adolescence, around, things like marijuana. It's like, well, if you're in a state where marijuana is illegal, has that today, 20 years ago, it was illegal everywhere.
Yeah.
But is that deterring people from using it? And it may be deterring some people from using it, sort of that perception of risk aspect. But there are plenty of people where it's not going to. And when you're at the point where you have an actual substance use disorder, and when we're talking about opioids, the whole legality is the last thing, on someone's mind. It's more about day-to-day survival. And when we're talking about opioids, it's about how do I not go into withdrawal today? So that's just doesn't come into the equation. And again, what it deters people, pregnant women specifically, from is asking for help. The stakes are just so much higher in terms of revealing that she's, one, pregnant, and two, that she is using substances and needs help. It goes back to when we think about 42 CFR Part 2 and that confidentiality, and having that federal law that adds extra protection and confidentiality to information about substance use disorder treatment. That law, I think it was 1972 or 1974, you may know better than me, that it went into effect federally. And the reason for that was because of the stigma. Because the belief that people, if they thought that their neighbors would know, that their teachers would know, that their church members, whoever, may know that they're struggling with a problem, just through asking for help and receiving help, that they wouldn't do it, that they wouldn't get help. And so with this extra protection that is still in existence today, though there are some challenges to it, which is a whole other interesting thing around, I'm not sure if it's helpful to go there, but today there is, particularly with the opioid crisis, our public health friends have gotten more involved in substance use disorders and discussions and policies and activities around it, which is great, because ultimately substance use disorders are a health issue. And we can't forget the treatment aspect and all that we know as substance use disorder professionals about the significant impact of stigma and the history of stigma and how that plays out. And I think one of our challenges that I see right now is that our public health friends don't understand or see that as much. And so there's this advocacy for really opening 42 CFR up and changing it in a way so there's a lot more access to information in the interest of more collaborative care, which is a good intent. However, we know that on the other hand, the folks involved on the ground level may still be, we haven't changed as a culture enough. So I'm right there with our public health friends in terms of what would be best practice. However, that is if there were not still the stigma and the shame and the moral or moralizing approach around substance use that we still very much live with and have to manage in terms of supporting people to know that there even is help out there and to get into treatment and to be in recovery. And manage.
That's a whole other policy issue I do find fascinating, kind of
Mm-hmm.
unintended consequences of integrated care. Sort of the idea that some will hold out that if you want problematic substance use and addiction to stop being stigmatized, then stop making it so different. And let's get away from 42 CFR Part 2 and move toward HIPAA.
Mm-hmm.
However, it is stigmatized, which is why it seems to make some sense to have some differences and some barriers in place. Listen, let me get back to this if I can. You mentioned that a woman who is pregnant, actively using opioids, that is not a crime in North Carolina.
Correct.
When this infant is born, they will be born with some exposure to opioids. They may have a dependence even on opioids, correct?
Yeah, they may have physical dependence on opioids if mom was consistently using, and in this example, I'll just clarify that we're talking about illicit opioids.
Yes. Okay, very good. Thank you. So now there's not an infant in utero. It's a individual member of society, if you will. How does current policy intersect with that reality, or is it a non-issue?
Great question. So in 2016, there was federal legislation passed under something called CARA, and within it, it updated, and that's an acronym, of course, it updated CAPTA, another acronym, which is related to child welfare federal funding that states receive. And so within that legislation, one of the things that it did was revised how guidance and requirements to how states respond to substance exposed infants. And so it was in response to the opioid crisis, but it's not specific to opioids. I will mention that the most common substance that infants are exposed to in utero is alcohol, still, not opioids, but how infants look when they're born after the exposure is different. And so while alcohol exposure actually has typically more lifelong damage because it's a known teratogen in utero, so it can cause permanent brain damage that may not be evident until the infant and child is missing significant developmental milestones. But they're not screaming and going through withdrawal at birth. And so they don't draw the kind of attention that infants exposed to opioids have. And so that's just an aspect of that's worth mentioning about what's been going on in the past few years.
Is there a correlation with the quote crack baby scare of a generation ago, and maybe the fear that's out there now about the opioid dependent babies?
Yeah, I think that's a good point. So chemically, just again, it's sort of it's one of those things that again is counterintuitive. So legal substances like tobacco also has a very significant impact on the developing fetus. So the legal substances actually can cause significant damage and problems. So alcohol and tobacco do that. They are the most commonly used substance in utero and do cause problems. And when we talk about, like I mentioned with opioid withdrawal, you might have some pretty dramatic symptoms of that for an infant.
Scary. Sure.
And so that really gets, people's attention legitimately. And then with crack, on the other end, as opposed to it wasn't and is not, and people still use crack, withdrawal, it's the effect of the, still the effect going on for that infant, depending on how recently mom used. Same with, methamphetamines and all of that. But yes, to go back to the crack baby thing. And so what happened then was this prediction of what was going to be true for all of those infants that were exposed to cocaine, to crack cocaine, in that period of time where there was significant amount of use of it. And there has been longitudinal research of those kiddos over time. And what it has shown is that the most significant predictor of the outcomes for those individuals over time is whether or not they were living in poverty and the environment was the most significant thing. So not the exposure of cocaine in utero, but whether or not, I'll leave it there. And so that is something that I think has been significant in trying to help people understand. I feel like one of the things that I do in terms of the front line work is try to translate things for frontline folks and help them understand, like, we've been here before. There were these, one, I will say that what I talk about is person first language, and person first language is significant for infants too. And so rather than talking about, and that's why I do crack baby, babies exposed to crack, or now infants exposed to opioids, we've got a lot of folks still calling infants exposed to opioids NAS babies, and NAS is neonatal abstinence syndrome, or a syndrome that is associated with withdrawal in infants. And unfortunately, that label leads to stigma and predictions about this individual, which are just not based on fact and are not fair. And I worked in schools with some of the kids earlier in my career who were identified as crack babies, and they knew that label. And so they would, that was still with them, in 3rd, 4th, 5th grade. And what a profound thing for those kids to be, and no doubt it's because the adults were referring to them that way. And that's just wrong. So we don't want that to happen. And so anyways, you asked me, this is about policy. Let me go back to policy. So in North Carolina, and across the country, because of that, so I'm going back to CAPTA. So all states were told that they need to develop something called a plan of safe care. And they were supposed to prior, but for most states, they were just calling what child welfare, if someone was screened in for and had an open case in child welfare, they were calling the plan that they had the plan of safe care. And the Fed said, nope, that doesn't count. That's not enough. So we want all substance exposed infants to basically have a more expansive view of what is happening to support their families. So there's this risk identified, and there may not be an acute safety risk. And that's really, in this state, has been the role of child welfare, with the exception of a few counties who've been able to do prevention work. But the role is really about acute safety of that child. And so they'll screen out, or not open a case after an, assessment investigation when there are not acute safety needs. But what about all those screen outs? Should they not still, if it's been identified that mom is struggling, because of the substance exposure, that's sort of a red flag, how about connecting her to treatment? How about really seeing that as prevention work and creating this safety net? So the expectation is that that's what a plan of safe care would look like, and that it would be interagency. So it wasn't just child welfare that was creating that or working on it. It was really, it required the involvement of public health, of in this state, the Division of Mental Health, Developmental Disability, and Substance Abuse Services, and other folks. And so I was involved with that work, and to some degree still am. And so interagency state level collaborative came together because what the Fed said, okay, you all have to have this and it has to meet certain criteria, but each state decides what that is. And so we were given 3 buckets that we had to define. So again, each state was given 3 buckets. They had to define what it meant and then what the plan of safe care was. So we had to define for North Carolina what a substance, and this is federal language, substance abuse affected infant is, what an infant affected by withdrawal was, and what an infant affected by fetal alcohol spectrum disorders was. And so the federal requirement is that healthcare providers involved with the delivery and care of a newborn are required to notify, not report, but notify child welfare of the circumstances of the existence of an infant that meets one of those three criteria: affected by substance abuse, affected by withdrawal, and affected by FASD. So in North Carolina, and we've got a website, it's on the DHH website. If you want to Google infant plan of safe care, the definitions for each of those three buckets are there. It is up to, most infants are born in hospitals, so it's hospital folks who are supposed to be aware of those definitions and then picking up the phone and notifying child welfare.
I wonder if we can actually drill down a little bit tighter even.
Sure.
I wonder if, first I found it interesting that the alcohol was separated out from all other drugs, because each, of course, will have their own presenting issues, it sounds like. So let's go to a social worker working at, hanging a shingle, working at an agency, and they begin working with a mom who is pregnant, and the social worker understands that the mother is also using some kind of substance that the social worker is concerned will harm the child, let's say opioids. Does a social worker have a duty to report to anyone?
Not during pregnancy. But I think that one thing that I do tell folks is it's important for all of us working with pregnant women to be aware of these policies, because we don't want her to go underground, right? Because this is bringing child welfare in a way, the way that it used to be before this new policy and federal law in North Carolina, more or less, was that if there was a positive toxicology screen on the infant, then there was a call to child welfare. And in terms of child welfare's screening practices, generally those would be screened in. And there seemed to be sort of an understanding between the hospitals and their county DSS that was the case, that's why they should call, because they're going to screen it in. I will say, I understand over the years that in some counties, they didn't screen in marijuana. That's not state policy. And it's just an interesting discussion about whatever beliefs are behind that for counties. And actually, I've heard that is still true in some counties. And the reasoning is because they would have too many, which is not how you, not how you do policy, actually. You work, it's like, I will, as a macro thinking, person in some ways, I would say, well, that's, you sit down with a whole bunch of people to address how to, educate and work with all folks involved about why it is probably better to not be smoking, at least during pregnancy.
I think it unveils a historic problem of expectations without funding. And I think I hear you saying, yes, but you don't just stop by cutting a corner. You get the right people in a circle and figure out what to do.
Right. You're identifying a problem, and looking away is not solving the problem.
Any parting thoughts particular to students that are working with families?
Well, I think I would say the awareness and understanding that there is treatment for pregnant women is underwhelming. And so that is sort of a continual need. And so for them to know that, and actually under that federal block grant requirements, pregnant women are a priority population. And so they go to the top of the list, and pregnant IV substance using women are at the very tippy top of the list. And so when you're calling your LMEMCO to get, perhaps if you're an outpatient provider, a higher level of treatment, because that always needs to be assessed. And in particular, I will say during pregnancy. It exists, and we have it. And we have a good team of people at the state level, which includes myself, that are very strong advocates for getting women into treatment, and will get involved on individual cases to make sure she gets where she needs to go. And so that's just really crucial to understand, because we know timing is everything. If any individual says, you know, I think I'm ready, I think this is I need some help, we need to jump on that. And the window when she is pregnant is just very limited. And so, yeah, I think that's one of the most important things to know, as well as parenting. She can get into treatment with kids. There may be a wait, but we have folks that will work with her to try to keep her engaged until she can get that bed. But typically we're talking about a week to 2 weeks. It's not indefinite at all. Yeah, I think that's one of the more important things.
That is a wonderful piece of advice that you know, we can apply immediately with the families that we work with. So I think that's very helpful. And I want to thank you for, you know, not only holding that safety net, but helping to weave the safety net, working at both the macro and micro levels. Your hands are full, because there's so many paradigms in our culture that probably go all the way back to the war on drugs, and this idea that if we make the penalty stiff enough, then people will choose to act right. And there's maybe that works for some, but certainly doesn't work for all. So, Melissa, thank you very much for joining us today.
Thank you so much for having me. And Mike, if any of your students have more questions, they can always come. You can send them my way. My dogs are getting rowdy right now.
You warned us. Yeah,
I did. Right. I did.
It's all good by us.
Okay.
So
okay.
yeah.
I'll try not to be distracted by them. So